Afternoon, everyone. A very, very warm welcome to this very special session. We will talk about the session in a few minutes' time. Let's start, as usual, our Annie activities with our Annie anthem. I'll just share request. I know you are not on video. Please, as usual, we stand for the anthem.
We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do.
Good afternoon, everyone, and a very, very warm welcome to this very special session. We know that for years we all have been working in hospitals, working with patients, and we are also aware how patients they get lost in systems. I have seen it myself, and many times I think that if I don't belong to the hospital, and when I can get lost in a new system, what could be the predicament of normal patients who go to hospitals every day? So I am very, very proud that we are having this webinar today. My name is Tanka Gomez. I am the founder president of Association of Nurse Executives India. And Annie, in short, every road leads to patient safety. And I think involving patients is one of the most critical limb of achieving that patient safety. And we are very proud Annie is collaborating with Patients for Patient Safety And we have none other than Madam Nadira Chaturvedi. I have known her now for a couple of years, and I can say that thank you so much for being so passionate about this cause. And this was one area that was, kind of unaddressed for many years, the voice of the patient. So you have brought that voice to the forefront. Give me a few seconds to introduce you to the audience here and all those people who are going to watch this video later. So, ma'am, Ma'am Nadira Chaturvedi is the co-chairperson of the Patients for Patient Safety Foundation. And and PFPSF, Patients for Patient Safety in short, strives to provide people with well-researched, reliable knowledge about medical issues that crop up along their health journey for protection, detection, and for taking prompt action to reduce harm, even if they face a dangerous medical situation. And this was not available for a long time for the patients. Now they have a ready place where they can go in and find information which is made in India for them. And ma'am, as a management consultant, academician, and social entrepreneur, holds a MBA from Indian Institute of Ahmedabad and boasts over 40 plus years of experience in corporate sector. Additionally, for the past 15 years, she has served as a professor of business studies, imparting knowledge to postgraduate MBA students. Demonstrating a commitment to social development, she has actively contributed to projects focusing on the health and education of underprivileged and marginalized sections of society for over 17 years. So, we have a personality here who is very socially responsible and have done great work in different domains. And now she's connected to each one of us through this foundation. And when I look at the amount of work the association has done since I have come to know about you, I feel sometimes that if I was the CNO, my God, I'll be going to that site all the time and trying to use all that information to help our patients because patient education remains a challenge for caregivers because they are so short of time, they are so busy, and you have got so many tools that they can download and use. So today I hope that all the people who are here and all those who are going to watch this recording later will get insight into all that you do and they will make commitment to do something about it. This is what is more important. Not just listen and say it was a great webinar, but decide that we are going to access the site and do what we can do for our patients. And they are our collaborators. Thank you once again, Ma'am Nadira, for taking time out for this webinar and a very, very warm welcome. And over to you now. All the
Thank
questions
you.
as we go through, please put it in the chat box. We can take it at the end. Thank you so much. And keep yourself muted and off video unless it is required. So that will give us discipline in the session. Thank you so much.
Thank you, Thangam, for that lovely introduction. It's nice to know that I'm noticed, but
Oh,
I'm actually
more
just an
than
invisible.
noticed. Yeah, more than noticed, ma'am.
I'm just a simple person, just a member of my family, of my friends, of my groups around me. As a patient, nothing more, nothing less, maybe a caregiver. These are the two hats that I wear, and these are the two hats that I bring to you today. I mean, I am in awe. That was a lovely anthem, by the way. And thank you for inviting our foundation here to express and explain what we do. And I hope at the end of it, as ma'am said, you'll get motivated to, use the tools that we offer you. Everything is free of charge, just incidentally. But let me begin by my appreciation of the nurses, of the nursing profession, and of all the doctors and providers of healthcare that I address today. It is the first point of contact is always a nurse. The last point of contact is always a nurse. And everywhere in between, it's always a nurse. So I would really say that this entire journey that we are doing, we have learned from you. We are sharing with you only what we have learned. And that is what I mean by engaging us and listening to us. Uh, we began this foundation about 2 years ago, just to set the context, 3 years ago now. And it was the one mandate that reduce medical errors and improve patient safety. I really had no knowledge of these two words. They all had a story. We all patients, every family, every member. If I ask you to shut your eyes for just 5 seconds or maybe 2 seconds and think back, and I mean that, close your eyes and think when you had faced a situation within your immediate circle of somebody falling sick and you are looking after them or they are looking after you. Just imagine, recall anything that went wrong. I'm not asking you to say it, but I think all of us, if we keep a 2 minute looking inward, we will come out with a story. I'll share my story as well. And I'll share good stories and bad stories both. But the medical error, this term, patient safety as another term, was new to us. And it's only when I interacted with the healthcare forums that we realized that every patient, every man, every woman, every family has this. And this is what we are bringing to you because, as ma'am said, there was nobody to listen to us and not only speak, but there was nobody to listen to us. So today's workshop, therefore, is focusing on what we have as stories, what you will convert into data, what you will convert into change of health care systems, and how you will sustain that throughout your particular area of work, whether it is before, whether it's during, or after in the care continuum. So let me begin by, and this was the first thing, that information that came to us. This is a classic one, 1 in 10, 4 in 10. I mean, it's like, it's like a tables that a child learns, two twos are four, two twos are six. But it was shocking. 1 in 10 people in hospitals do suffer harm for various reasons because of various people. It's not only the healthcare. And as many as 4 in 10 patients suffer harm when they're beginning their journey in the healthcare. Now, this harm was explained to us. It could be medication errors, it could be surgical mispractices, like the classic example of Sri Devi, a very famous actress, everybody knows her. And her mother fell ill. Sri was rich, wealthy, she had resources. She takes her mother to New York, gets her surgery done, her brain surgery, from the best of the doctors. And unfortunately, it was the wrong side of the brain that the brain was operated on. As a result, she loses her eyesight, she loses her movement. She had to go for a second surgery for the other side, but I think it went wrong. So, what went wrong? It was the surgical site marking. So it was, anything can happen to anybody. It's not just poor people, it's not just rich people, it's not but literate or remote or rural people, anywhere. You talk about hospital infections, you talk about radiation errors, blood clots, sepsis. So there are so many reasons, and that's where our journey began. We began to relate, to collate stories of harm, and who does it? Why would does it happen? When I attended my first CAHOCon, the first IPSC programs, I was just flabbergasted at the amount of dedication, sincerity, and each time I've attended a session by the nurses, particularly Annie or anybody, every year. And I'm impressed that research is happening, improvements are happening, even NABH accreditation standards are changing, and yet harm happens. So we came back, and although we had gone, the chair, Mr. Somital and I, we went and said, okay, we must talk about it to patients, we must talk about it to doctors. Oh, no, 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 we were so wrong. We were really wrong. We came back and we said, okay, let's think. Who is the perpetrator of this harm? Does a nurse do it willingly? No. Does a doctor do it deliberately? No. Does a patient do it deliberately? We had a moment of silence. We had a moment of truth. Yes, because of our negligence, ignorance, or just surrendering, or tensions and misunderstandings, patients and caregivers quite cause twice as much harm as that happens in the provider's domain. There is, of course, it doesn't mean that none of us are responsible. All of us are responsible. So this was our first acknowledgement that yes, we are human. We will make mistakes. There is a shift change. Too many patients. One nurse is absent. The load comes on the other person. The doctor hasn't come. Children are crying. The handwriting is poor. Communication incomplete. Forgot to put it in the system. So there are systemic errors, there are human errors, and there are pure lapses. So this is what our starting point. And we started making a list of the possible errors, which I'll share with you, and why and how, where do they happen and how they can be prevented. So if I begin like a story, I mean, my own it's a personal story, okay? And there's a good story. My husband was a very fit man, a very able person. Everything was right. And he went to the dentist again and again. The dentist, for 15 years, he was going. For the last 2 years, he was suffering pain in his teeth. It's a family problem. We said, okay, fine, no problem. And we went back and forth, painkillers, extractions, etc. Ultimately, after 2 years, it was discovered it was stage 4 mandibular cancer. Now, who was at fault? Both the system as well as, I mean, I would take partial blame. Should I have gone to somebody else? I don't know. But these are the questions that come to our mind as a patient when I am not getting cured, when my first symptoms appear. I don't even know whether it is serious. I mean, I'm giving the same example. When my husband is to complain about spicy food or feeling burning in his mouth, I said, okay, you go to Kerala and you have that lovely food. You don't grumble. You come home and even if I put a little pinch of salt extra or a pinch of chili extra, you grumble. So I did not take those symptoms seriously. And the same thing happens when you go to doctors. Is the diagnosis correct? No, 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 no. This cannot happen to me. Why are you doing so many tests? I just did an MRI. Why do I need a CAT scan? No. I said, they're just making money. And I don't even know when my last CT was done. I don't know when my last preventive health checkup was done. I just think everything is expensive. The system is all wrong and it's only commerce, commerce, commerce. So I don't get answers to the questions. And this leads me more emotional stress, more sickness, and the disease keeps quietly but surely advancing. Somebody has to answer these questions. There is nobody right now who answers these questions. So we began to collate these. And in our website, we have something called infrequently asked questions. But somebody can give the answers. If I don't get an answer, what happens? Let's see. So then again, we went back to our own thought processes. Our journey in the medical field, or I call it a train, it's literally a train of 6 boxes, begins before I enter your hospital. Tracking symptoms. Is it harmful? No. Then the diagnosis is delayed. Is the diagnosis correct? I don't want to take tests. I don't want to give information. I have seen patients, I've done a lot with cancer care, and there are people who do not want to admit that the girl child has cancer because then she will not get married. Her in-laws will scream. So when there's a problem or a recurrence, the doctors are not told, especially if the mother-in-law is taking her, and the cancer progresses. These are real facts. These are real stories. I'm not cooking them up. So when you give incomplete information, obviously the diagnosis is wrong. And who's blamed? The doctor, the nurse, the hospital. Treatments. I mean, we all know. We go to the chemist. He's my best friend. I tell him I have a stomach ache. I have a gas problem. I have loosies. He gives me some medicines, not realizing I might be on some other medication. End result, doesn't work, may not work. It's unsatisfactory at best. My fever comes down, I leave it. But then I have a fever again. And I say, doctor did not give me the right medicine. So all these things, including the post-care or the preventive choices, are purely harm done because nobody answered my questions. Nobody explained to me. And this is what I'm talking about: patient engagement, patient education. End results, we expect a lot. We expect that the nurse is kind to us. We expect that she tells us everything. We expect the doctor to explain what's wrong with my heart. I want all my information. I want the dignity. I want everything. And it's particularly the bottom right hand, if I draw your attention to coordination of care. This is a very, very tough one for you, for us, and as a family. My sister has lupus. She's got paralysis. She's got heart, and now she's got cancer for the last 4 years and she's bedridden. Getting the 4 specialists together in her hospital, she's in Bombay, is a nightmare for her son. But who's to blame? And then I have 2 sisters who are doctors. They call up from America and they want to talk to the doctor again. So the coordination, not just of the specialists, but the coordination of the caregivers is another nightmare for the nurses. So the point I'm trying to make is errors happen. Errors happen for various reasons, and errors happen because both of us. Is there a solution? Or shall we just blame each other, build, a trust deficit? I think the answer to us in our foundation is creating awareness among people, among ordinary citizens. We are not dumb, we are smart because our body matters to us, our family, our loved ones matter to us. So if someone created better awareness, better education, better information, if somebody really engaged with us, then we would do all these things and help each other. And I don't mean that you don't have empathy. It's not sympathy. I mean a deeper. I mean, I have a 16-year-old, 17-year-old granddaughter. And I tell her, clean the room, keep your room well, eat in time, drink your milk. She doesn't do anything. She's at an age when she wants to deny me. But if I tell her why, not what, I mean, why I should do it or why you should do it, immediately she comes on board. So the reason behind it is as important as the action. So if you tell me that I keep a systematic records in a chronological order, not just one episode at a time, I got my insurance, it's done, I've lost my files, I've lost my bills, done until my next episode. Because in our body, every episode is connected. It's a chain, it's a necklace. And the doctors and the nurses want that. Do you all have time to gather the history, which I myself don't know? I don't think so. But if I was an aware patient, I would start by keeping my records, tracking my symptoms, and end until I give you the feedback so that it gets better with every circle, every cycle. This is what our foundation is doing. And this is where you are trying. And as nurses, because you're the first point of, I know everything is a funnel. Anybody does anything wrong, I find the nurse is blamed. I mean, it was, it's natural because you spend much more time than a doctor. It's true. And but you have problems as well, and we have problems as well. Your problems are where there are too many patients, too many languages, too many differences in literacy levels. I mean, you mentioned United, you are proud of your work. I heard your anthem beautifully, right? You want to do things better, brighter for the future, and you're trying. But there is a difference. This is where the difference comes. I don't mean to blame, please, but this is where we are trying to identify the problems so that we can solve the problems. When you tell me I have a carcinoma or a Hodgkin's lymphoma or a non-Hodgkin's lymphoma or a myeloma, I mean, it's Greek and Latin to me. You tell me I have cancer, I understand. You tell me it's a cardiac arrest, it's a heart attack, it's a heart failure, makes no sense to me at all. You tell me your heart is failing, I can understand. So there is certain languages that you speak, which you need to speak. Your taxonomy is different from my taxonomy. So the medical jargon, the rushed communication, the assumption that I know all the medical terms is wrong. On the other hand, when you talk to me, I already overlaid with anxiety and fears, and it's a boon, but it's also a bad thing. The internet, Dr. Google comes to my rescue, and now there's artificial intelligence as another, perpetrator there. Information overload, but it's misinformation overload, according to me. So there are so many reasons why we need to simplify, clarify, and make something complex and decomplex the whole system. That's where we come in. That's where you can use our work. And that's where you don't have time, but we are here to offer our services because we understand the mindset of a patient. We understand where we are coming from, why we need the answers, and you are the one who will give it to us, but you can take it straight from us. So what Patient Safety Foundation does is we begin, as I mentioned the train, we begin with the symptom journey. We highlight the risks and the causes. Even while we are in the hospital, we tell you what can go wrong and we give you actionable tips. So Thangam ma'am was right. It's not just information for the sake of information or gathering a certificate. No, it is something that we can do about it. And the most important point in our work is what can a patient or a family member or a caretaker do, not only the healthcare worker. You will do it because that's your job, but I have to participate, and the partnership between providers and people who receive care is where we come. That's why I'm not talking about rights and responsibilities. I'm talking of the role that we need to play. So the keyword role is higher to me than rights and responsibilities. Okay, so that's where we are, and this is where our system works. So how does it work? Why does it work? Where does it work is what the next part is going to be about. And people trust us. We began our outreach. We do various things. We do text, videos, audios, webinars. Our posters are very, very, people like it because it's simple. We have translated into 11 national languages and we give it in every form, websites, social media, on your WhatsApp, in your web, everywhere. Okay, so it's easy, it's trustworthy because we always verify it. What we do not give is clinical advice. We do not step over your toes. I won't say take this 625 mg antibiotic. I won't say go and take that 1.5 saline. No. But I will say, if you don't do it, what will happen? And this is just to illustrate. This is some of the things that I would do. I'm sharing with you just an example. Okay. There's a lot of work now happening on digital screens. We are all doing that. Okay. But people are having trouble. People don't listen. But if I give you a lecture, nobody's going to listen. But if you put up a poster in the children's room, in the children's ward, how to sit, how to protect your eyes, we are accepting reality and not blinking it. There's so much about dog bites. There's so much about thin and 5 injections. It might be better if you actually prevent it. So this is just an illustrative, but as we go along, I'll take you further into that. So, this was just to illustrate. So what we are doing, therefore, we are bridging the gap between patient and providers. Let me give you another story. Again, a real one. This was 19 years ago, almost, 18 and a half. This was my second day of my sixth chemo. I myself am a cancer survivor. It came unexpectedly, no warning, healthy, happy young lady, 2 children, great job, everything. And each time I went for my chemo, I had my family with me. Every time. I was never alone. I was lucky that way. Okay. And my daughter was always with me, or one of my sisters. We are a large family. As usual, we went day 1, day 2. The nurse said, please have your protein sandwich. We're going to give you the saline. We're going to give you the antiemetic. Then we'll give you the dangerous cocktail of toxins. And then you again have an emetic, and then you can go home. And she told my daughter something. I don't know what she told her. I took my paneer sandwich. I hate paneer, by the way. But anyway, I had it. I took my book. I was resting, and I almost fell asleep, which I usually do. But this time, my sleep was not sleep. I was in a semi-coma. I was collapsing. I was sweating. I was red-faced. I had cold sweats. I was shivering, and the book fell from my hand. Obviously, I didn't know all this. My daughter told me this later. My daughter rang the bell. The nurse came. There was no doctor on call. There was a huge seminar going on. All the 100+ doctors in a large, excellent hospital were in that big seminar hall. The nurse immediately brought a life-saving kit. She injected me with something. She discontinued the saline that was going into my body, and she revived me. It was that angel. It was that nurse because of whom I'm sitting here today and talking to y'all. I don't remember her name. In my mind, her image has become fairer and fairer and bigger, but I have never forgotten her. What did she do right? What did my daughter do right? Both of them were right. The nurse gave her information, which she had given 11 times earlier. Mine was a 2-day protocol. But every time she repeated it, that if this happens, if this happens, if this happens, these are the signs you should watch out for, and call me if something goes wrong. She had her tray ready. That was her system going right. My daughter was not lost in her mobile phone, or just taking the fish trays, or it's to us, hospitals are always picnics. I've gone so many times. We go and order something great from the canteen because it's like room service and paid by my parents or my grandparents or whatever. But my daughter was more clued in. The moment she saw the book falling from my hand, she rang the bell. She realized something was wrong. So that was patient engagement. That was caregiver engagement. And the nurse and my daughter saved my life. That is the power. That is the beauty of telling each other, listening to each other, communicating with each other. Of course, there was an RCA done after that. It happened to be cobwebs in the saline bottle. It was a whole batch was rejected. The vendor was changed. The system was put right. And there were multiple checks put in the system when you procure something. That's for later. But now we're talking about where and how we can engage with patients. And that is why I wanted to spell it out. It was not a doctor who saved me. It was a nurse who saved me. So thank you, nurses. I'll always be grateful to you. And therefore, caregivers have to be as important as nursing because we are nurses at home. 90% of the time, especially a woman, a mother, a daughter, a sister, a wife, a cousin. We're always nursing somebody or the other, ourselves or someone else. So whether we are in outpatient care, whether we are in inpatient care, or whether we are in home care and follow through care, I think 90% of our work depends on this. So this is a chart for engagement. I'll be more specific as we go along in each stage. And in our foundation, we have created a tool, we have created designs, we have created patient education, ready-made material, simple, easy, attractive to follow in multiple languages, which you as a nurse, which you as a delivery of carer can do anytime and also give it to us. So there are two advantages here. One is you will learn, one is I will learn. Together we will learn. In your anthem, multiple times you said together, multiple times you said unity, multiple times you said, brighter, and these words were used. And you want to make a difference. Let's make the difference now. So I'm taking the outpatient, okay? I'm coming back to another example. A literate, qualified, clever person in our friend circle has a indigestion problem. Okay, we all eat outside, we all have indigestion, we all take a medicine, we take khichdi, we take a lemon juice, we simplify life, we get better. This person did not get better. 1 month, 2 months, 3 months, 6 months. They changed their diet, they changed the water, they changed their country. They came back to India, didn't go. Ultimately, finally, it was colorectal cancer. Why? Because they did not tell the doctor about all the symptoms. They hid it. So when I come in an OPD or my first consultation and I call up a random hospital and I say, I want an appointment, I don't even know whom I have to meet. I don't, honestly. I mean, my daughter recently, last year, it's almost 11 months now, she woke up one morning, she had a severe backache. Later on, we knew it was a slip disc, but it took us 3 months to know it. So we asked, and they said, okay, go to see the physician, the orthopedic, the spine specialist, the nerve specialist. I don't know. I don't go there. Ultimately, somebody explained to us that you got to go step by step. So when I do this, this is a whole circle which keeps repeating. I call up, I come to the hospital, somebody has to tell me which doctor to see. The doctor says, go and take this test. I take the test, I go back to the doctor, and sometimes I vanish. Believe me, I vanish because I feel nothing's wrong with my reports. I can read them, but I can't read them. The doctor can connect the dots. The nurse can connect the things. I can just see one thing. They can see the whole picture. And I go for a review, or I don't go for the review and I follow. So these are the points in the pathway where we need each other's help, where we make errors as patients, caregivers, and you can also make a slip up because you're overloaded. Therefore, at the very first call, if somebody at the registration desk tells me, are you a member, ma'am? Do you have an ID? Do you have a number? Sometimes I have 3, 4 people in my phone number, so I have to bring different IDs. Bring an attendant. Where shall I come? I end up going in the emergency because there's no queue there. In the front desk, there is a queue, but that's wrong. That's wrong of me. So you have to tell me, are you giving me a time? I know the doctor will always be late, so I come late and then I blame the doctor. Okay. So whether it's an online appointment, whether it is a walk-in or whether it is an emergency situation, I need to carry my medical history. I need to carry my notes. I need to be accurate. I need to be honest. And you need to explain to me the value, because earlier a doctor used to have 20 minutes to take a history. Now the doctor has 3 minutes. And 70% of the work is done by the technicians, by the machines, and the diagnostic lab. See the difference. We were so happy and satisfied when a doctor checked us, touched us, asked us about the whole family, our children who were not yet born, our children who are dead and gone. But there was a human touch. For the sheer overload now, everybody gets the best of treatment, and yet we are not happy. We are not trusting each other, we are not telling each other, and we're unhappy with each other because of the low engagement, the dropping engagement. Even now, whom do you think I prefer to go to? Why do we prefer nurses? Because at least they talk to us, they listen to us, they touch us, they feel us, they feed us, they give us medicines. Doctor doesn't have the time, but a nurse has to help the doctor. If a nurse did all this before I met the doctor, I think it would help both of us, all of us. I would be less tense, right? So maybe a may I help you desk, a queue management. Sometimes I'm sitting in the OPD and somebody just walks past, enters the doctor's room because either they know the doctor or they're bringing a report which was left out. But as a patient in the waiting queue, I get upset. Why are they taking them? This is not a good hospital. There's nepotism here. So if you only put up a chart, the second last bullet on the left side, updating patients on real times. If the doctor is late, please tell us. If he's in a surgery or he's in his rounds, I will understand. You tell us he's 20 minutes late. Don't say he's coming, he's coming, he's coming. Many times we sit in the usual room and we realize the room of the doctor has changed. We're wondering, where is my card? Where is the doctor? He's come and gone, ma'am. You didn't come. Because I was sitting in the wrong place. Because the doctor changed his room. Okay, the doctor can change his room. Did anybody tell me? No. It's like missing a flight. I sit in the wrong gate and the doctor goes off from another flight. So small things make a big difference. We get upset. These are systemic, but also it can be helped. And encouraging us to ask and understand our disease, I think to me that is the key. For example, there was another patient, another friend of mine, she had had a surgery. She had a chemo pot and she goes home and they said, you're normal, you're fine, everything is great. No need to come back, all good. She goes back, she goes in the rain, she walks. Obviously, her wound gets wet and she gets infections. So tell us when, why we need some engagement. Maybe you have time, maybe you don't have time. Diagnosis and treatment, another touch point. This is another big thing. Diagnostic is going bigger, better, faster, and more expensive and more detailed. Now there are genetics. Now there is predictive, apart from preventive. So there's a whole new dimension, which I understand the value, but I don't understand the cost, and I don't understand why I need it. Again, somebody who's prescribing the tests, if they told me why I need it, whether it is to investigate, whether it is to confirm, whether it is to monitor, then I will understand. My brother-in-law had blood pressure. Nobody knew it. It was Diwali time. He kept having mithai. He refused to monitor it. He refused to do a monitoring test, which he was supposed to do every month. His sugars shot up to 700. He was in a near coma. Luckily, his wife took him to the hospital and his life was saved. But it was a test which was missed out. So if you explain, these tests are not to change your medicine, these tests are monitoring your medicine dosage, it might be there. And everybody knows about the handwriting problems. I think there's a rule now that medicines should be typed out, capital letters, and even within that, OD, BD, TDS. It was a very funny incident. This, as children, we play tic-tac-toe. So there are knots and crosses, circles and crosses. So that's what I find in a prescription. Some doctors like crosses, some doctors like circles, and some doctors like dashes. Now, whether the cross means I shouldn't take, whether the cross means I should take, I don't know. So somebody has to explain that to me. Otherwise, it just becomes a game of tic-tac-toe. So small things, but errors begin because I took it on the wrong time. And you did not say, you said morning, but you didn't say before breakfast. You said before breakfast, you didn't say empty stomach. So a lot of work has to be done here. I don't know whether you have the time, but we can give you that information. So even the follow-up, the do's and the don'ts, both are important. The negative signs are important. Everyone says, do this, do this, do this. Nobody says, watch out for what not to do. And sometimes you do tell us, and we call up that number. Nobody answers because it's a line number, 2646. Nowadays, everything is gone into mobiles. It's a dead number. Please let us know which date the doctor comes so that we can follow up. So there's a lot of work. There's a lot of things that can happen. And although you all are rushed, I think the system, the timetables, the technology needs to be updated. And this is what we're talking about. These are some of the samples that we can share with you in our OPD areas. Preparation before visiting a doctor. To us, this has been a very, very important and a very successful poster. Just 5 bullets. The nurses are happy, the doctors are happy, the patients are happy. What did I write in that? First bullet. Jot down your symptoms before you come. Prepare your questions and doubts before I come. Because, classic example, I come to the doctor, I enter, I'm flustered, I'm late, I'm rushing for a meeting, or I got in a traffic jam, and I forgot to ask two questions. I come out. Oh, I forgot to ask him. I rush back. Doctor, that medicine is not available. Can I take another one? The doctor is kind. He looks up at me and he says, yes, change, or he says, no, don't change. I come out rushing. Again, I forgot. Doctor, can I take it before breakfast? He says, next, please. So doctor has no more patients left. But if I had my list of questions in advance, I think the doctor would answer me. But and the same thing goes for my history. Diagnostic errors, communicating whether I have sugar, communicating whether I've taken an aspirin, verifying the site, the name, the number on that thing, the color coding. I think all these can help. In your OPDs, instead of putting up what Trump did or what Modi did not do, or which politician hit which politician else, I think perhaps some health literacy, some signages of women, children, anything about illness would help. Not just promoting a new doctor that joined you, I don't mean that, but age-wise symptoms, pain-wise symptoms. I think these things would bring your hospital a better light, better loyalty, and more respect. And without taxing the nurses or the doctors. This is what we are creating. Similarly, in the inpatient, I think you got much more time, right? Right from the admission, insurance, ward timings, at least 3 days somebody stays, 3 to 7 days, 9 days. The checkups, which are done every day, the checkups which are done periodical. It could be surgical, it could be pre-surgery, pre-anesthesia, it could be post, and of course at recovery and discharge. So there are lots of times here, there's lots available, and this is where you are strained the most. Now take for example, in a ward, all right, I'm giving you a scenario. Most of the work is done by nurses, the doctor comes for his round, goes back. Imagine a ward with 4 patients, 5 patients. One bed is empty. I love that bed because it's next to the window, so I change my bed. Another bed, the caregiver is very, very smart, clued in, noticing everything that's happening and not happening. A third patient is very clueless, no attendant, just sits quietly. And in comes the fourth patient who's critical, just coming in from a major surgery and a recovery room. 4 different scenarios, okay? The nurse comes rushing in, she needs time. If the nurse had engaged with the clued in caregiver in the ward, number 3, that person would be attentive to his own patient. That person can take care of the person who's silent. It's dangerous when people do not talk. I think to me that's more danger than talking. So that the nurse's time can go to the person who's critical. The fourth patient who's a hypochondriac who comes there only because it's a social life, I think the clued caregiver can take. So by engaging even with 1/4 of the people as caregivers, nurses can save 100% of their time. These are real scenarios. And again, the same thing, right from filling the form of the admission to the insurance counseling. This is a great, we always fight here when we get the bill. When we admit, we said, oh, I'm ECH, I'm entitled to a big room and I'm going to take the best of the rooms. So I take the room. I don't realize that there's a multiplier on the consultant's billing, on the anesthesia, on the OT, on everybody who visits me. And when the bill comes, I say, but I didn't ask for this, but I didn't pay for this. I only pay for the room. But that's not how the hospital systems work. And then I get into a fight. Or cashless, cash claim, advance, eligibility. So I think an insurance counseling and a financial counseling before I enter is more important than fighting at the end of it. So I think all these things must be put up, even if we have the right to engage. The ward, as I mentioned, is the orientation of the ward. Very few nurses have done this. I bring food from outside. Always I hide it in my purse. I'm admitting it because I don't like hospital food, but that's wrong. I may give it to the patient. I may bring infection into the hospital. So you need to tell me why, not just the money saving. It's not about the money always. It's not about the taste always, but it's about the that's why you don't allow flowers. So the rules, when people can come, when visitors should go, where is the waste disposal, why I should be, clean, including hygienes. Many times I've seen on the bedside table, there's a glass, there's a water bottle, there is an anesthesia, no, sanitizer at the foot of the bed. And I know my mother-in-law always carried back the tissues and the extra sanitizer and the extra thermometer and the extra. She said, we've paid for it. I know we've paid for it, but we also paid for it to use it. And she would never use it there because she'd always get it back home. But that sanitizer on the foot of the bed is so that you clean your hand each time you touch a glass, the bathroom, the door handle, the mug, or the patient or the patient's IV. So hygiene, and if you don't do it, you end up with hospital-acquired infections. I mentioned about the surgical site marking. It was tragic, but it's true. I'll bring here the Martha's rule. I think all of you know Martha's rule or the new thing. A little girl called Martha kept saying she's not well, not well, not well. All the medicines were fine. The doctors were happy with the reports, the tests, but she was unwell until she felt really, really sick. And from that came the rule that a patient is always right. In management, we have this jargon, customer is always right. And I think the patient is always right. Asking them how they feel, believing them that they feel uncomfortable, finding the cause that they're uncomfortable, or at least reporting that cause and seeking another opinion, I think will change healthcare remarkably by involving the patients. As Thangam said, that involving the voice of the patient is what you do. All you have to do is listen and report. You don't have to do anything more. During recovery, during discharge, oh my God, discharge, another pain point. I'm sure all of you would agree that we are miserable because of the discharge processes. We are miserable at the discharge timings. I'll give you another real example here. My husband was in the hospital for 9 days. Major surgery after his whatever facial thing happened. We were coming back home, and I was flustered. It was tension in the house. There was the dirty clothes had piled up. The kitchen had piled up. There was not too much domestic help, and I get this list from the dietitian because he was on a rice tube. Give this, give this, give this, and the dietitian goes away because it was 5 o'clock. She went away, and it was almost 7 o'clock. So I come back home. I put the rice tube in place. I had brought 2 bags, and she had said, give dal chawal. I came back. I cooked dal chawal. You know how I cooked it? Like I cook it normally. Big, thick, lumpy khichdi. I tried to put it in the bag. It wouldn't budge an inch, a millimeter. Nothing went in the tube. It was too thick, too dense. I was panicking. I had to give him medicines. I cannot give him on an empty stomach. It was already 3 hours since we'd left the hospital. He was on a 2-hourly medication routine. I ultimately threw that bag. Luckily, I always buy 2. I just took protein powder, mixed it with milk, and I gave it to him. Because nobody told me the consistency of the food that goes into the bag. Nobody tells me how often I should clean it. Nobody tells me how often I should change the catheter. Nobody tells me how often I should throw the urine that gathers in that bag. So there's lots of stuff that happens at discharge. Perhaps a suggestion, a practical suggestion, start teaching the caregiver 1 day before the discharge timing. You all know tomorrow is discharge. All of y'all know. Y'all are smarter than us. And don't just tell us, do the teach back method. Tell us what can go wrong, not just what goes right. Tell us how to do it. And there are checklists. Share those checklists with us. So when we go back home, don't ask us how we are. This is another great one, feedback. Oh my goodness. The moment I come, there's a feedback nurse, black suit, high heels, tick tock, tick tock, tick tock. She's come from the PR section. She's come from the front desk. Ma'am, everything all right? The nurse is trying to find my vein, which has gone lost. She's given me 3 pricks. Then she called the senior nurse, who's so expert that in 1 prick she gets through. I'm worried because something is going to start. And I just tell her, yes, everything is fine, go. Why? Because I wanted to get lost, not because everything is fine. So she says 5 upon 5. What is that score called? You call it something, NOS or something, right? And she gives a great review. It's hardly a great review. I go back home and I backbite her on the social media when I finally get time. So follow-up, feedback are not the same thing. Ask me when I've calmed down. Don't ask me when I'm near the nursing station because there's chaos always there, because the files are coming, the doctors are coming, the reports are coming, they have to write down, they have to give medicines. Let me go. I choose the furthest corner away from the nurses, furthest, because it's quieter there. And that's when you can ask me for the follow-up. So call me 2 days later, call me 7 days later, I'll be much better. So there's lots to be done. And this is some of the things that we created from our own experiences and from our own mistakes. All that we've done is both mistakes from us and there, and these are learning from the examples. See the center one. Discharge checklist. This is for the patient, not for the nurse. This is for the patient. Did I receive the discharge summary? Did I take all my diagnostic reports? Did I understand the medication? My sister-in-law was going back home. Housewives are always busy. The nurse was kind enough. She said, I'm giving you 5 doses packed in 5 packets, morning, afternoon, evening. The white goli, red goli, pink goli. My sister-in-law came back home. She calmed down. She got back into her kitchen, her laundry. By the time the 5 days were over, she was settled enough to make her own medication lists. That's a nurse. That's being empathetic. That's when I understand that I must take this tablet in time. Have I gathered my billings? Have I gathered my medical certificates? Have I gathered the emergency numbers? So this checklist will help the nurse that, okay, even the patient has understood. This is what we call two-way communication. Falls. I believe it's a huge crisis in hospitals as well as in, at homes. So we have created these simple charts and these simple tools. Call, don't fall. I think you should change the heading. All of you can do that. Call, don't fall. Okay, let's just rename that. And call the call bell. No, I want to get up in the night because I don't want to disturb my child who's sitting next to me. And I get up, I slip because my sensorium is compromised. Boom. The first problem is one side, the second problem starts. Similarly, we've done for medication safety. So there are lots more posters. There are hundreds of them, but I'm just giving you examples where you can use which one. I've already explained. Your care doesn't finish in the hospital. This is a misnomer. Your care begins when I'm discharged, because that's where patients come in, that's where caregivers come in, and that's where problems happen. So please include this in your care continuum. It is not over when I leave your gate. There is another 90% beginning when I leave your gate. Explain to me post-hospitalization care, whether it is PT or whether it is yoga or whether it is medication, rest or recovery. Explain to me my diabetes care, my heart care, my cholesterol care, my obesity care. Explain to me how elderlies can prevent becoming worse or at least maintain a quality of life. Palliative and end-of-life care, symptomatic care. You cannot cure, but you can care. So these are real things that we are propagating to be included, including in the accreditation standards, including in the care standards, delivery, as well as providing us. Okay, so there's lots here. Some more material, just for examples, just sharing that with you quickly. Preventing falls at home, emergency, ice charts, etc., etc. So just to summarize, take a breather. Why should you look at this? What is it? Nurse leaders, NLPE program, inpatient empowerment. You are the leaders. Annie is a leader. Each of you is a leader. You are the link. It matters because you're the link between the healthcare system and the home care system. The communication gaps, the mistrust, the harm, it all falls through. So you focus on strengthening your voice. You focus on transforming care. You've mentioned it in your anthem. You need to transform with 3 things: education, engagement, 2 things, and empowerment. Education, engagement, and empowerment. It benefits you personally, it benefits you professionally, both. As a leader, as an individual, your attrition will be less. Your pride, you mentioned in your caption, proud of what we do. Be proud of what we do with this. Be confident. Your stress will come down. The trust in the system goes up. Your effectiveness, your health outcomes will come in. For this, we are offering you tools, which ma'am has said, we've got ready-made tools. We can send you copies. If all of you, one request, please send us separately on the email address. I can provide that, or the phone number, your hospital name or the CEO or the address. We'll courier a free of charge copy, a printed copy of our toolkit. where we have touch points, where we have patient education samples, and we also have a suggestion of how to use and how to disseminate it. These are available on our website, but we can send you hard copies as well. So for example, when I meant the touch points, I mean, the what I've written up, we see the last column here, errors made by patients. There is, I mean, a whole lot of errors. 17 areas have been highlighted where we make errors. But the beauty is the tips to prevent it by healthcare, the tips to prevent it by us. So we're giving you a ready-made, tried and tested. Several hospitals have already used it successfully, and they keep asking us for more and more and more. The second education, second tool we are offering you is pure education. This is continuously expanding in languages, on multiple topics, in formats, and this is a never-ending thing. Use anything you want, everything you want. It's clear, simple, easy to understand, and attractive to put up. You can put up as charts, you can put up as posters, as flyers, or as QR codes. So how do you disseminate? We've also suggested flexible, variable maps in your hospital, in your care facility, from front desk to admission desk to OPD waiting areas, outside canteens, outside pharmacies, in anything, any footfall areas. Exact locations are given, and you can have, visibility, etc. These are, see, what I was saying was like this. You can have videos on the screens. You can have a QR code in the middle. You can have a poster on the wall. You can put this, please add this to your training and healthcare. We have also created 10 training modules, incidentally, which will be passed now in the KahoCon coming up in April. And a feedback room, mobile friendly WhatsApp information. You can register with us. It's all free. It's all voluntary. And of course, we've got social media. So we've got this panorama. This is real stuff. This is real people in real hospital, how they're using it successfully. We've got testimonials from CEOs. We've got testimonials from quality experts, research experts, nurses, NGOs, families, and caregivers. There's lots more, but I'm just giving you as a patient, as a QCI, as a CAHO member, as an NGO, as a medical director. So Annie, thank you, Annie, for doing this. You can benefit by putting up our free posters. You can do it by clearing our doubts, improving the understanding, reducing confusion, because that's where problems happen, improving your bedside care, because you have ready-made material, you have more time. There's a standardization. One nurse can tell one patient once. One nurse may tell 10 patients once. One nurse cannot tell 100 patients everything every time. We understand your burden. We appreciate your work. We love you. And therefore, so the last two slides, to sustain it, this is on a bigger level, I understand, but since you're leaders, you can promote this in your CXOs or the CEOs. Patient advisory councils, we've got manuals on this. It is a voluntary combination board of patient representatives and providers of care, including doctors, nurses, irrespective of department or hierarchy, where we identify the chronic problems, we find solutions dispassionately, we address them, and we give it back to the system for continuous improvement. In fact, NABH 6th edition has made it a tool of excellence in their standards, that we should have patient engagement and we should also have patient advisory councils. We're getting there. So trust us, believe us. I'm talking as a patient, I'm talking as a woman, I'm talking as a mother and a daughter, but we also have doctors who've given us great advice. There are lots of people who've done it, including Annie people, right? All of you. Many partners, private sector, public sector, partnership, healthcare systems, hospitals, large corporates, small NGOs, nobody and everybody is important to us. So there's more going on. You can take a screenshot of this. This is especially for you nurses. A free, safe health library with all the materials, with posters in your language, the toolkits which you can save, access easily. And since it is real time, since we are updating our website real time almost every day, every week, you can use it. We have a Thursday newsletter that goes out. We have a Friday WhatsApp that goes out. We have a podcast every Saturday. Today we did a podcast with a doctor patient on bone health and joint health. So we have several dynamic things that are happening. Join us to save us. Join us to help us. so that together we improve healthcare and we don't blame each other. Thank you for listening. I hope people understood. We'd love your feedback. We'd love your suggestions. We'd love your knowledge. We invite you to share your knowledge as well with us. Open to feedback, open to questions.
Thank you, ma'am, Nadira. That was really what I'm at loss of words. Something that had been in the waiting for a very, very long time. And I think any hospital who will not take advantage of all that you have created, I think would be doing injustice to their own services, not to anybody else, because we all are committed to give wholesome
Yes,
care, which includes patient education, engaging
right.
them. All of us learned that when we got into the profession, but as you rightly said, because of the quantum of work and you don't get enough time to tell everything to
Yeah.
every patient.
Everywhere.
I think it is right time that we should use the tools which are already created available. And as you said, these they should not be treated as small things. They are really big things because all the stories that you told are really true. It can happen with anyone. Just because the right question was not asked or the right answer was not given, they assume a lot of things. So we also have stories, that can, like you
Yes,
told about your brother-in-law with 700 blood sugar. There are a lot of stories we also have, and we all are trying to do our best to see that how best to educate patient. I think that was a wonderful, wonderful, eye opener to all the people who are here and all the people who are going to look at this recording later. I I endorse that, all of us should visit your website and download the tools and use it for the best for the patient. Make patient our partner. It is their body, it is their
yes,
system,
it is.
right?
Yeah, they know it best.
And World Health Organization repeatedly talks about engaging with patients, especially for reducing medication errors. Because
Yeah.
if they
Yes.
are aware, at least they will ask question, they will stop us from giving them something wrong. So it's wonderful session. Thank you so much. If anybody has any question, any comment, please come on the screen. You can, come on the video and share your thoughts. Yes, we are waiting.
I'm always afraid when nobody asks. That means they either didn't understand anything or they understood everything.
I totally agree with
Hello,
you.
Sangam.
It goes two
Hello, Geeta
ways.
ma'am. Uh, I have three requests. Number one, to all the nurses here, first of all, our gratitude and our thank you and our appreciation. Please do share your IDs or your phone numbers or your addresses so that we can send you this material as soon as possible. Second, we need your knowledge. We need your stories. Tanga ma'am said stories. We've been asking for more stories. They will be anonymous, trust me, but we will draw lessons from it. We will add them to our questions and we will add them to our answers so that our topic list is enriched in real time because you all are doing it real time. We may have anecdotes, you have a whole, data file on that. So the second is stories, and the third is your knowledge, your expertise, whether it is hygiene at home and the errors that we make. We would be really, really obliged, I would use the word, to get the information and the knowledge that you all have. We will build on it, promise that. Everything we do is without charge, so and without anybody's name. Thank you. Please do share that with us.
We will definitely work
Varsha,
towards that,
can you
ma'am.
just put the info ad on the thing? Yeah.
Yes, ma'am.
Ajita ma'am, comments.
Hi, Nadira ma'am, everybody. As always, it's a sheer pleasure listening to you. I got in a little late, rather,
That's
but it's high time. We would not be intelligent enough if we don't use our patients for their own safety and our safety, right? So, and there is a clear-cut ways as to how to engage them if someone is confused or how to educate them. All that is there. It is up to the public to use that, including the healthcare workers. And thank you so much for doing so much for patients and all of us. Really appreciate you coming and sharing your experience with us, and I'm sure it will go a long way for the nurses to adopt from this. And I'm sure these materials, if someone uses it effectively, will be making their life much more easier as to how to go about doing various things, and creating visuals and creatives to use that. So great to listen to you, and I'm sure we'll continue to associate. Thank you so much.
Thank you. Thank you. I
Thank
think
you.
somebody wants to say something. Yes. Yes, ma'am.
Thank you, Dr. Nachita. I'm having Manipal Hospital. You want to say something on the screen? You're muted.
Yes, ma'am.
Yeah.
Thank you, ma'am. It is am I audible, ma'am?
Yes.
Yes, yes, you are.
Actually, we have to involve the patients from the door to till they leave. It was very nice. We have learnt a lot of inputs, ma'am. Actually already I was a member. I have been getting the
Right.
mails. Thank you
Yeah.
for it. And from the organization mail, I will again send it for the
Please,
teaching
please.
material.
And we're also doing trainings. I'll add two things. We're doing trainings for the nurses separately. We're doing training for the non-technical staff as well. And we can do hospitals. If there is enough audiences, we can repeat this within a hospital group. Because some of you have many beds. You know, I mean, at least 100 people should join. Then we can do a special webinar for a closed group. I mean, like Asta did it for 500 people. James did it. So people are doing it within the hospitals, and we're available for that.
Okay, ma'am. Sure.
So
We'll try
even if
our best,
sometimes you don't
ma'am,
want to
to
join
stay
as a nurse,
connected.
from that time, okay?
Thank you,
Including
ma'am. Thank
the
you.
patient advice. Thanks a lot. Thank you.
Yeah, I think one idea to all the people who are here who are going to uh, watch this video is also that you can schedule, as ma'am told, you can schedule, you can have this room full with nurses and other people, and you can request for a webinar like this, and then
Hmm?
um, the the speaker from the Patient Safety Foundation can come and
Okay.
introduce to all this, Ma'am, are you the only one doing the webinar, or you have others who do the webinar?
With me? No, Mr. Somital also does, and we're getting doctors as well now. So we'll
Okay,
be having that
okay.
on specific topics, So apart from that, we're also doing it for the general public. Like this was the healthcare style. We're also doing it for corporates. So every 2 months, we have different topics where anyone can come in. It'll be like open. Anyone can join us. I mean, your sister, your cousin, your nephew, anybody. It doesn't have to be only healthcare providers. So we're trying to reach out to the
Anybody
masses
who's
in
hospitalized
multiple
can
ways.
go and attend the webinar for the
Yeah.
patients.
Okay, great. So thank you everyone, and maybe we'll be having more such webinars on different topics maybe in the future. Thank you for joining, and thanks to the people who are going to watch this recording. And please get in touch, or you can go to the website of Patients for Patient Safety Foundation, and you have access to all the tools, as ma'am told. They're all free of cost. So it's just your desire to do something for the patient that is required. Rest all is already made available by the foundation. So, Ma'am Nadira, thank you so much
Thank you,
for
sir.
taking
Thanks.
the time and being with us. And thanks, Varsha, for coordinating and making this happen. And thanks, Ajita, for joining. Thank you, everyone, for being here. Take care.
Let's keep. Thank you. Bye-bye.
Bye.